Good afternoon, everybody. Myself, Dr. Niraj Vasavada. I'm chairman of Online Education Committee, Asia Pacific Spine Society. On behalf of Education Committee Chairman Dr. Ajoy Shetty and entire EC of Apss, I welcome you all to this third basic seminar uh, on junctional fixation techniques. We are going to cover occipitocervical, cervicodorsal, thoracolumbar, and sacropelvic junctional areas. It's a great privilege for me to invite today's chairperson, Dr. Muhammad Arif Khan, who is a very renowned surgeon from Pakistan. He's Secretary General APOA. He's past President-elect Society of Spine Surgery, Pakistan. He's a past president of Pakistan Orthopaedic Association. May I hand over the proceedings to today's chairman, Dr. Muhammad Arif Khan. Thank you, sir, for gracing the occasion.
Thank you, Niraj, for your kind introduction, and hello, everyone. It's indeed a great honor for me to be part of this webinar. As we all know, junctional fixation techniques are always an issue, a challenging issue for the spine surgeons. And therefore, today's theme, the junctional fixation techniques, occipitocervical, cervicodorsal, thoracolumbar, and sacropelvic fixation is very relevant. And I'm very thankful to the APSS, particularly the Yatwa as president, and the education committee, the Ajoy Shetty and Niraj Vasavada for running this series of webinars. And I'm more particularly very thankful to all the participants for attending this webinar today, because without their interest, it would not be possible to run these webinars. Today, we have a panel of 5 great speakers: Dr. Masato Tanaka from Japan, Dr. Ronald Tangente from Philippines, and Dr. Umesh Srikantha from India. They will present their talks on the principles of fixation. And then Dr. Nugroho Setyowardoyo from Indonesia and Dr. Jun Tan Hao from Singapore would present their cases. In addition, we have 2 moderators today, Dr. Christian from Malaysia and Vijay Kumar from India. We had a 6th speaker, Dr. Sudhir Srivastava, who was supposed to present a video on occipitocervical fixation, but unfortunately he could not join today. So without wasting any time, I would like to hand over the session to the moderators for proceeding.
Thank you very much, Professor Arif, for introducing the session. My name is Chris Chan. I'm from Malaysia. I'm very excited with the lineup we have today, as well as the program we have. We have indeed a star-studded cast of speakers. So without further ado, I would like to introduce the first topic of presentation, which is on principles of management of occipital cervical fixation and use of assisted technology. This lecture will be delivered by Dr. Masato Tanaka from Japan. Professor Tanaka is currently a clinical professor of the Department of Orthopaedic Surgery at Okayama University. He's also the president of the Spine Center Okayama Roadside Hospital. He's actively involved in AO Spine as an Asia Pacific Education Officer, Vice President, and he's also the president of the Japanese Society of Adult Spinal Deformity. So without further ado, I will pass the time to Professor Tanaka to deliver his lecture. You have 10 minutes, sir.
Okay. Good afternoon, dear colleague. I'm Masato Tanaka from Japan, not Malaysia. But thank you for your kind introduction, Dr. Chris and Dr. Khan. Today, I'd like to share our knowledge about OC fusion with you. So let's start my video, please. Today, I'd like to share about our knowledge of occipitocervical fixation. This is COI. Definition of OC fusion is a surgical procedure that stabilizes the junction between occiput and cervical spine. main purpose to treat instability caused by trauma, degenerative disease, congenital abnormalities, or tumors. This region is a highly mobile and vulnerable area. Proper fixation prevents abnormal movement, reduces pain, and minimizes the risk of neurological deficit. As you know, this region has a unique anatomical structure. 1/3 of motion of head flexion and extension is occurred in OC1 area. About half rotation is C12 area. This area is very mobile. That is why ligament structures are very important, especially cruciate ligament. One of the most common indications for OC fusion is trauma. OC1 dislocation is usually fatal. If patient survives after reduction and hollow immobilization, then OC fusion is indicated. This patient was longitudinal dislocation. We performed OC4 fusion. We usually perform OC fusion for degenerative diseases, such as C2 vertical subluxation and irreducible AAS. This patient is 67 years old RA patient. AAS was not reducible. We performed OC fusion. According to our study, OC fusion group had a higher complication rate and higher reoperation rate compared with C12 fusion. This patient underwent OC2 fusion. However, occiput screws were back out. Another indication are congenital defects such as os odontoideum and Klippel-Feil syndrome. This patient is 13 years old male, Klippel-Feil syndrome, dense compressed spinal cord, we perform ventral reduction like this. First, rotation, then dislocation. This is a post-operative radiogram. Final indications are neoplastic processes. There are many benign and malignant tumors in this area. Metastatic tumors are mainly from breast, lung, prostate, and thyroid cancer. This is 79 years old female C2 pathological fracture from lung cancer. We perform OC4 fusion. For surgical technique, there are two approaches. Anterior approach can achieve direct anterior decompression. However, only anterior fusion is impossible and high risk of infection. We usually choose posterior approach because this approach is familiar and safe for most surgeons. However, limited access to anterior regions and risk of vertebral artery injury. VA injury was reported from 0.14 to 2% for pedicle screw and 0.72 to 4.1% for transarticular screws. C1 lateral muscle insertion also have spinal cord and carotid artery injury. That is why we need spinal technologies. Advantage of navigation are high precision for screw trajectory at C12. Useful when anatomy is distorted. Reduces revision rates and enable minimally invasive posterior approach. Disadvantage are potential for registration errors or tracking drift, steep learning curve, and high cost and maintenance. Load of robot system are reduced hand tremor and fatigue. Disadvantage are high initial and maintenance cost and limited tactile feedback. This table is a summary of 3 techniques. Benefit of assistive technology are improved precision and accuracy, enhanced visuality, reduced operative time. Challenges and complications are technical difficulties, risk of neurovascular damage, and hardware failure. C1 lateral mass screw, there are 4 techniques. Goel technique is the first reported one. However, disadvantage of this technique is sacrifice or irritate C2 nerve root. Tan's translaminar technique has a high risk of laminar breakage and VA injury. Notch technique is the golden standard for C1 lateral mass screw placement, but sometimes a lot of bleeding from venous plexus. Our midpoint technique is very useful. If you have a navigation system, entry point is the midpoint of C1 lamina, which is between Tan and Notch technique. If you use this technique, you don't have to expose C1 to venous plexus. This is a 5-year-old Down syndrome patient. First, we put C2 pedicle screw, and then C1 lateral mass screw like this. We invented cervical pedicle screw fixation, MySeps. This technique has several advantages. Reduced soft tissue trauma, improved post-operative recovery, enhanced fixation strength, compatibility with advanced technology. Disadvantages are technically difficulty, risk of neurovascular injury. Within 4 cm bilateral small skin incision, pedicle screws are inserted without shear. Let me show you the video. Just 4 cm posterolateral skin incision and pedicle screws are inserted simultaneously, like this. This is very useful technique for pedicle screw placement. This is 45 years old patient, C2 metastatic tumor from lung cancer. First, we put occipital screws with navigation. Then, this is MySeps technique. This is a post-operative radiogram. Take-home message of my talk: posterior fixation with cervical pedicle screw is the gold standard for OC fusion. OC fusion has a higher complication risk compared with C1-2 fusion for AAS. VA injury is approximately 2%, which should be avoided with navigation technology. Minimally invasive cervical pedicle screw fixation, MICEPS, is a unique technique to avoid VA injury. Thank you for your attention.
Thank you very much, Professor Tanaka,
Yes.
for that lecture.
Yep.
So now we have approximately 8 minutes
Yep.
for discussion.
Mhm.
So any questions from the floor? In the chat box, I do not see any questions currently. Maybe I will start by asking the first question. Professor Tanaka, can
Yeah.
I ask, how do you decide on the optimal positioning of the head and neck for occipital cervical fusion or stabilization?
Thank you for your good question. So one of the most difficult complication is dysphonia and dysphagia. So OC2 angle is very important. So more than 20-degree OC2 angle is necessary. But simple one is you check neutral lateral cervical X-ray, and then fusion should be more extended one. Thank you.
I have one question, Professor Tanaka. First, thank you very much for very good talk. In the beginning, you showed a picture in which the occiput screws were pulled out. And this is not an infrequent happening. How did you manage these cases? And particularly in rheumatoid patients where the bones are very osteopenic, how much bone graft do you actually put in? And then your technique mainly is focusing on the navigation. So what will be your message for those people who are not using navigation?
It's a little bit difficult question. So I always use navigation. Even for the occipital screw, the thickest one, I check the navigation. But as you know, the center is the thickest one. And you should put a lot of screw into occiput. For cervical, if we use pedicle screw, so the distal anchor is very strong. But cranial anchor, I mean occipital screw, is easily pull out. So I always put 6 screw into the skull. And of course, we put a lot of bone graft, allograft, and also iliac bone graft. And orthosis is very important. So you should recommend patient, you always wear the color. And especially for Philadelphia type is better. Thank you.
Thank you, Professor Tanaka. I have a question for you. Since you are using a lot of enabling technologies, what is your experience about percutaneous fixations of this C1, C2, and occipitocervical junctions?
So one of my colleagues also do the percutaneous, I mean the posterior anterior fusion for C1-2. But usually for C1-2, sometimes we need decompression. In the session, we use midline incision. But to put the screw from lateral position, if you have a navigation, so usually I always see navigation image, not CM. I never use CM because we are so much afraid of radiation hazard. But if you don't have any navigation, sometimes axial view technique, it's Dr. Yukawa said, it's you make an axial view of lateral pedicle screw and then put the screw. It's relatively easy technique. Thank you.
Thank you, Professor.
Professor Tanaka, In cases whereby you need to perform a C1 laminectomy, or even when you need to decompress the base of the skull, and the bony surface for fusion is limited, then in those cases, how do we optimize fusion in an occipital cervical fusion?
Actually, I do a lot of Chiari malformation. So in that situation, we have to do foramen magnum decompression and also C1 laminectomy as well. But for Chiari malformation, we don't need any bone graft because it's no instability. But this is mainly for the tumor or for just irreducible AAS, we don't have to remove the skull. Just C1 laminectomy is enough. But if you remove the foramen magnum, so there is no good solution. But as I said, you should put a lot of bone graft, and sometimes you need extra, hollow vest or something, because it's very difficult to maintain the alignment until the bone fusion. So. Is that the answer for you?
Yes, yes. Thank you very much. Maybe one basic question which I want to ask is that what is your routine pre-operative workup for a patient who is actually planned for occipital cervical fusion? What are the key investigations which we must perform, and what are the key steps in planning which we must carry out before we execute the surgery?
So as you know, for the image, most important is, as you know, the MRI. But for examination, it's as you know, the Shimizu reflex. It's a sacropelvic reflex. If this reflex is hyperreflexia, this means upper cervical is a main region. So this is a very important reflex. And patients sometimes complain the occipitalgia and the ear pain as well. Thank you.
Well, what about for instrumentation? Any particular radiological investigations which we need to plan for the instrumentation for occipital cervical fusion?
So as you know, we always put cervical pedicle screw. So VA course is very important. High riding VA is a risk to put the C2 pedicle screw. And also sometimes VA is the dominant side and non-dominant side. So in that situation, you shouldn't put pedicle screw into dominant side. It's a fatal complication. Thank you.
Any more questions from the floor for Professor Tanaka?
Thank you.
So, Tanaka, do you feel any challenges which are specific to age groups, like in pediatric population? Is there anything different that you will do?
So young patient, it's not a good idea to fuse OC because the spine is still growing. So less than 5 years, you shouldn't fix the OC fusion. And elderly patient, the problem is osteoporosis. So sometimes you need a lot of screw in both sides. So OC1, OC2 is not enough. Sometimes OC3 and OC4 for elderly patient. But as I said, alignment is very important. Thank you.
Yeah, that actually goes to my next question. How do you decide distally whether you want to stop at C2, C3, or C4? Because I've seen some surgeons, it's quite variable. So how do you decide on the number of distal anchors?
It depends on how much instability. And if you remove C1, so it's much more instability. So we usually use C2 is distal anchor, but sometimes C2 screw is a little bit difficult. In the situation, we choose C2, one screw C2 and C3 screw. It depends on the instability and the bone quality and VA anomaly.
any tips on reduction if we are faced with bacillar invagination? So what are your thoughts on methods to reduce bacillar invagination?
So the Professor Abumi already reported a famous paper. So nowadays in Japan, they never do anterior decompression for basilar invagination or basilar impression. We put pellicle screw C2, and then rotationary distraction is possible. So it's a Mayfield should be rotate like this, and then some other stuff. Sometimes do traction, and then fix it. Neuromonitoring is necessary.
If I understand correctly, you are saying that there will be an assistant who is
Yes,
holding
yes,
the
yes.
Mayfield thumb.
Mayfield, and then
Then
rotate and disrupt sometimes.
okay. Do you insert any spacer between the joints, the C1 and C2 joint?
No. So the first reporter is Tokuhashi, and some Korean also reported, but it's not necessary for me.
Okay. So in those cases, you always manage to reduce the bacillar invagination with that maneuver?
It depends on how much compression is occurred. So slight compression and the symptom is not so severe. So just decompression is enough. But I present that case is severe compression and the patient cannot walk, very, very severe symptom. That's why I did a reduction. That patient is a Pakistani patient.
Thank you very much, Professor Tanaka. Like I said, you are a real star in this area. So thank you very much for answering all my questions and all the questions from the panelists.
Thank
So
you.
now we move on to the next lecture. The next lecture is on principles of management of thoracolumbar fixation. It will be delivered by my dearest friend, Dr. Ronald Tangente from the Philippines. He's the current president of the Philippine Spine Society, and he's also the current honorary treasurer of the Asia Pacific Spine Society. He is the program director of the Davao Doctors Hospital Clinical Fellowship in Spine Surgery and is the head of the Brain, Spine, and Scoliosis Center of Davao Doctors in Philippines. So Ronald, can you please share with us your thoughts on this topic?
Yeah, good afternoon, my good friend Chris. Well, anyway, it's an honor to be invited here, and since this is a basic course, I will try to focus on some basic stuff, so that everyone will probably learn a bit with regards to this talk. Uh, Anna, can you please share my video, please? Thank you. Good afternoon, everyone. Thank you very much for this opportunity. I was tasked to talk about the principles of management of thoracolumbar fixation. I have no financial disclosure. This is my lecture outline. When you talk about thoracolumbar junction, it deals with T10 down to L2. This transition zone lies between the less mobile thoracic spine because of the rib cage and the more dynamic lumbar spine, and this may lead to significant biomechanical stress. Unfortunately, 50% of these injuries are unstable. It may lead to kyphotic deformity, late neurologic deterioration, and even chronic pain. For those of us who have been in practice for more than 20-25 years, we are very comfortable doing an anterior approach. because we think that by doing so, we might be able to have a direct decompression into the cord. Likewise, we may be able to restore a strong load-bearing construct. However, this is more invasive and technically demanding. Nowadays, you can do an MIS with similar results. We are now very comfortable doing posterior instrumentation. To differentiate, short segment posterior instrumentation involve instrumentation of just one level above and below the fractured vertebra, while long segment posterior fusion involves instrumentation of at least 2 levels above and or below the fractured vertebra, with or without instrumentation of the fractured vertebra. Back in the late 1990s and early 2000, we were doing a lot of short segment posterior fusion using the concept of distraction ligamentotaxis. With the help of rod distraction, the posterior longitudinal ligament will push the displaced vertebral bodies, allowing more space for the spinal cord. Unfortunately, in my own personal experience and reiterated by Dr. Robert McLean, I had the fortunate experience of rotating with him at Cleveland Clinic in USA. He observed that high failure rate was seen in short segment posterior fusion because that was not adequate enough. We were using a lot of Cottrell-Dubuisset instrumentation back then, which led to high failure rates. It may lead to progressive kyphosis even more than 10 degrees. We thought initially that once we have a solid fusion, we may be able to avoid kyphosis or implant failure. However, posterolateral fusion with short segment posterior fusion does not provide sufficient strength. It may still end up with kyphosis and even implant failure. So in order to improve the construct stiffness, you may add screws at the fracture level in short segment posterior fusion. By doing so, it decreases the mechanical complication, and it will also increase your construct stiffness by 31%. So therefore, it may lead to good kyphosis correction and maintenance of reduction. Now, this is a 61-year-old female with T12 compression fracture. I did a 3-segment MIS fixation. Even so, I was still monitoring this patient for possible proximal junction kyphosis. I'm treating this patient with denosumab as well. MIS is still a very good option. It allows for internal bracing during fracture healing, also using ligamentotaxis concept. However, even at this point, there is a definitive data that is still lacking to support long-term fixation without posterolateral fusion. I would like to stress these words, physiologic load. This is a very good biomechanical analysis looking at 2-segment, 3-segment, and 4-segment fixation, testing for physiologic load, axial compression, flexion, and extension. Unfortunately, 2-segment fixation stiffness is significantly lower than the physiologic load. Therefore, this is a weak construct. Now, looking at physiologic load for long segment fixation, now we're talking about 3 and 4 segment fixation. It may lead to a stiffness of about 25 to 30% higher than the physiologic load in compression and 60% higher in flexion. The point here is that you don't need to have a very stiff construct. You just need to go beyond the concept of physiologic load. Long segment posterior fusion shows better results than short segment fixation. Now, 3-segment fixation is actually a good option because it does not make the construct too stiff. Now, this is a good finite element analysis simulation looking at Model A, wherein you have dual rods with 4 screws and reconstruction of the anterior column, while Model B looks at 3-rod construct with 4-segment fixation, and Model C, dual rods with 4-segment fixation. In this paper, they found out that short segment fixation with 4 screws and reconstruction of the anterior column resulted to the most stable construct. However, it led to so much stress on the uninstrumented vertebra. And this was also seen at model B. The thing here is that it caused the adjacent non-instrumented segments to bear more load, a phenomenon called stress concentration. It may run the risk of proximal junctional kyphosis again for model A and model B. They concluded that the two-rod construct posterior fixation resulted to the highest screw pull-out stress, meaning the maximum amount of force a screw can withstand from pulling outward before it fails. A higher pull-out stress indicates a stronger, more stable fixation. In this case, with a T11 chance fracture, I think I went beyond the physiologic load, and so this may be a stable construct. Now, for patients with highly unstable AO type C rotational and translational injuries, you may consider long segment posterior fusion. You need more points of fixation. A short segment instrumentation cannot be reliably used for ankylosing spondylitis. Now, I also would like to share the concept of working length of construct. This is actually best for AO type B and C fractures. Although these type of patients treated with short segment instrumentation with adding screws into the fractured level showed similar outcomes with long segment instrumentation. The good thing about the designs nowadays is that the designs of the pedicle screw resulted to a higher pull-out strength. Now, looking at patients with ankylosing spondylitis and diffuse idiopathic skeletal hyperostosis, it is recommended to increase the working length by using posterior fixation of at least 3 levels above and 3 levels below to avoid failure of fixation. Now, this patient has an L2 pathologic fracture. I tried to increase the working length a little bit and put some screws at L1 and use cobalt chrome rods. And I also tried to put the screws at the end plates to make it more stable. Now, the concept is that you need to have a stable proximal and distal anchor points. You may either skip a level to increase your working length, hoping to increase the overall stiffness. The key factors are you need to put the screws at the superior end plate's posterior half. You might consider convergent angle screw, increase insertion depth, and additional purchase at the stiff anterior cortex. Now, looking at cobalt chromium rods versus titanium rods, cobalt chromium rods has better ability to correct deformities and kyphosis. In titanium rods, however, it has the higher incidence of rod failure. However, if you use cobalt chrome rods, you have to think about the possibility of an increased risk of proximal junctional kyphosis. In this 10-year-old patient, 6 months paralyzed with toppling sign, I had so many problems with small pedicles, low BMI, unstable spine with kyphotic deformity, and unfortunately financial constraints. I was left using lateral muscle fixation, having my UIV at T8 down to L3, and using 3.2 millimeter rod diameter. Unfortunately, this patient had wound descents, and after a month, this patient was able to stand up. After a year, I ended up with proximal junctional failure. The year later, I had to remove the construct and kept her in a hyperextension brace. I will need to closely follow up this patient for future considerations. The factors that influence the effectiveness of posterior instrumentation, low BMI, rod diameter, and implant density. So I had those problems initially in that particular patient. The other important message that I would like to share is that you need to avoid your upper instrumented vertebra at the apex of the thoracic curve because of a higher risk of proximal junctional kyphosis. If you have the choice, you either end up at T9 or even at T10 as your UIV. This is a 65-year-old with a very unstable spine, multiple myeloma. I had no choice. I had to go beyond the apex of the thoracic curve. Rod fracture can happen over time because of fatigue or either because of delayed union or pseudoarthrosis. It may happen after a long spinal fusion. Unfortunately, it may still happen even with a solid fusion mass. In this case, I ended up with a fracture after 2 years post-op. I revised it using cobalt chrome rods and had more fusion material. I could have used multiple rod construct. This is a T12 TB of the spine. Unfortunately, this patient ended up with a rod fracture after 3 years post-op. Because this patient is asymptomatic, this is non-clinical significant rod failure, I decided to just keep it in place and just having a closer follow-up. Take-home message, I would like to acknowledge our colleague, Professor Rajasekaran, Rishikana, and Ajoy Shetty. Number 2, critical steps in the surgical technique. You need to consider unilateral fixation and temporary fixation before manipulation of the unstable spine. Avoid torque forces. And the most important message is the 5th one. You need to perform laminectomy to allow more space for the spinal cord before you reduce the unstable deformity. And the most important message is that you need to review the principles of spine fixation. Thank you very much. I would like to invite you in Cebu next year for APSS 2026. Again, thank you very much.
Thank you very much, Ronald. Dr. Tanaka.
Yes,
you have a question.
Yes, I have a lot of questions, but the first one is nowadays, even for AS or this patient, 2 above 2 below is it's a Japanese standard because we can use augmented screw and transdiscal screw. Do you have any experience to use augmented screw? Number 1. Number 2, so I have never heard thoracic lateral screw. Could you explain thoracic lateral screw?
We do not have, excuse me, what's the first question about?
It's a augmented screw with cement. It's becoming very popular. And transdiscal screw, even though you are not using the transdiscal screw is penetrate the end plate, so it's very strong. It's 1.6 times stronger. That's why a lot of paper are coming from Japan. 2 above 2 below is enough now.
For AS.
What do you think?
Okay, I think it makes sense, Professor. I think the augmented screw fixation also makes sense. However, it also depends on the availability of those implants. I have no argument. It is actually a good concept, and I also am aware of the concept of passing through the disc, because the advantage, Professor, is that you actually hit 3 cortices, right? So so it has a higher pull-out strength. You also need you just need a a longer screw for that fixation. So I don't argue with that concept. It really makes sense. Thank you for that suggestion.
Okay, another question is thoracic lateral screw. I have never heard that one. Thoracic lateral screw.
Yes, that was meant for a child, Professor. And then we had a CT scan, and that was actually the child had a very small pedicle diameter. And so instead of using the regular 3.5 pedicle screw, that would actually not be possible for that small child. So we had no choice. In fact, we also had a meeting similar to that in, I think, KL. One Indian surgeon was also using lateral mass screw for very young children. I think the point, Professor, is that if I had a choice in that particular, that is why I had, that was an issue, that was actually trying to give a lesson to everyone that you have to improve the screw density, right? to improve your fixation. If I had a choice, I would have used a smaller size pedicle screw, but in that situation, the available screw was just the lateral mass screw for the cervical spine. So yeah, I was pushed to the wall in using that. That was a lesson that I shared to everyone. So there are things that are limited, for example, in our world, even I'm sure in some other parts in Asia, that we have some limitations with regards to the implant choices that we have in our armamentarium. So we just have to adapt. The problem is, in some situation, we may get away with some complications, but unfortunately, in some situations, we fail. And the message is that I'm trying to share the failures that I learned over the years. And so some of us will learn from it. Thank you for that point, Professor
Then
Tanaka.
maybe I can just clarify. What
Thank you.
Ronald meant is that he doesn't mean that there's an anatomical lateral mass in the thoracic spine, but he
Yes,
used a cervical system to insert a pedicle screw for
yes,
for
exactly.
in the thoracic spine of a child. So I think that is what is meant by a lateral mass screw. Uh,
Yes.
am I correct, Ronald?
Yes.
Yeah.
That's a
Okay.
challenge, Professor. That's a challenge.
Okay,
So
I
Okay.
see. I see.
yes,
I see.
yes. It's a
Yes.
ingenuity, but we have to learn our lessons also. Thank you, Professor.
Okay.
Ronald,
Yeah.
I have a question. Uh, as you know, most of the new spine surgeons, they are moving away from anterior approaches in thoracolumbar region because of the morbidity associated with diaphragm injuries and these things. And they are doing more and more posterior. And I also saw most of your cases are from the posterior. But we also know that, and you mentioned it, that 80% of the load passes anteriorly. And if the anterior column is incompetent, it's very difficult for only posterior column reconstructions to support that. So, what are your indications for anterior column reconstruction in trauma, infections, and tumors in all these cases? Because few of your cases, particularly the multiple myeloma and others, I saw anterior column was very bad, but you have done only posterior fixation.
Yeah, I think that's a very good question. So you also need to look at the biomechanical concepts also. Initially, I thought over the years we really have to have a very stable construct. I don't argue that doing a anterior column reconstruction is not a good option. In fact, it's a very good option, which actually provided a stable construct. Years ago, we were doing a lot of that. I'm sure, Professor, you're very familiar with it. We opened the diaphragm, fixed it, and then even we turned the patient and fixed it posteriorly as well. Now, I think the in some cases where we need to do anterior reconstruction, especially for deformities, is that if you need to do significant kyphotic correction, I think you need to, and then you have some very unstable anterior column. I think it is necessary to do anterior column reconstruction in addition to the posterior fixation. So nowadays we can actually put uh, anterior column reconstruction to posterior approach, and I that's a very good concept also. But for maybe just for single level involvement of that area, you might be able to get away with just posterior fixation. So the other argument is that would would more than 50% vertebral body loss be a good consideration for anterior column reconstruction? I think it is. It is a good concept, but I cannot give a perfect answer for that, Professor.
Okay, in infections, particularly in tuberculosis, what is your
Yes.
procedure of choice in thoracolumbar junction involving T12 or L1?
Yeah.
What do you do? Just posterior or anterior posterior?
Yeah. In our region, we still have a lot of uh, TB of the spine in that particular junction. In most cases, Professor, we do away with just posterior. Yeah, in most cases, but there are certain cases that we really need to do a 360 fixation.
Yeah, I think this concept of doing the 360 from the posterior approach alone is gaining popularity And it's just like you are doing a vertebral column resection, but a much lesser magnitude. Particularly in infection, it becomes a lot more easier to do that.
I think the advantage of doing TB from the posterior approach is that it's not as bloody as we thought it would be. The pathology and the bleeding tendency for TB, so it's relatively easier to go from posterior going anterior. I agree with that, Professor.
Maybe I just we are running to time now, so maybe I just ask one last question. How do you deal with instrumentation misplacement, whether intraoperative or detected post-operative?
Misplacement.
Means
You mean?
pedicle screw mount placement.
Okay. So what specific question about that, Chris?
Two situations. One is
Yeah.
that you detect it intraoperatively, whether it's medially malplaced or laterally malplaced. Second is that you detected it after surgery. So
Okay.
what would you do?
So I think
Yeah.
the first situation is quite good because we can actually adjust. So I don't think that's a very, very bad situation. Like most of us experienced surgeon, it's easy to reposition it. With regards to, again, this is another concept that we should also understand. The pedicles by itself has the ability to expand. So we can actually put bigger screws in that area. The other point that we need to understand is that even if you have a break in the medial cortex, generally you don't hit the spinal cord. So you don't need to be very afraid of that. But again, if you find it intra-op, it's actually best to just reposition it. So I don't think that's a big issue, repositioning pedicle screw. The second question is that if I'm out, then that's another problem that I need to discuss with the patient if I need to come in again and reposition it. I never had that situation where I need to come back and reposition it. The other thing is that if you actually missed one screw, generally, if you somehow feel that it is still a stable construct, somehow you may get away with not having to replace that screw if you notice it post-op. That's a big, but I think what is important here is that informed consent. If you think that that's really out, you probably need to inform the patient about it. Did I
Thank you
answer
very
your
much.
question?
Yes, thank you. Thank you very much, Ronald, for the great lecture and discussion session. So we will proceed to the next lecture, which is the principles of management of sacropelvic fixation. This lecture will be delivered by Dr. Umesh Srikantha from India. Dr. Umesh is a director at the Neurosurgery and Clinical Lead Spine Services Fortis Hospital at Bangalore, and his main interests are in MIS surgery, endoscopic spine surgery, complex spine surgery, stereotactic and functional neurosurgery, and neuro-oncology. So I'm looking forward to listen to the wisdom of Dr. Umesh with regards to this topic. Please take the stage.
Thank you so much, Professor Chan, for that wonderful introduction. Is my screen visible now?
Yes.
Yeah.
Yeah. So thank you so much, and it's wonderful to be here. And once again, thank you, APS's committee, for giving me this opportunity to present our experience in sacropelvic fixations. And I'll also be dealing a little bit about the principles of management. So compared to the other junctional areas that we are talking about today, the lumbosacral junction or the lumbopelvic junction, is quite unique. It's very obliquely placed as compared to the other junction because of the sacral slope, and it is most mobile in the sagittal axis as compared to the other junctions. And it has highest transitional forces, which can be up to 100 newtons. And sometimes the lowermost point of fixation that we commonly consider, that is the S1 pedicle screw, cannot be can sometimes be not strong enough to support these kind of transitional forces that the segment is subjected to, especially if there is a long segment fixation. And also because of the lower sacral bone density and paucity of cortical bone in the sacrum, there is a higher chance of implant failure rates. Now, there are some small points or some small concepts that we need to
know about before going into a lumbopelvic fixation topic. So one is the McCord's LS pivot point. And as we know that this point is located at the junction of the posterior ligamentous complex and the disc, at the level of the L5S1 disc. And we also know that the surgical implants that cross anterior to the pivot point are more effective as compared to those that say posterior. And the more anterior it goes, and that is the concept of iliac as well as the S2A screws, the more anterior the construct goes, the more stronger the construct or the implant strength becomes. The second concept is the zones, the sacral zones that we already know about, which was proposed by Brain. And in these cases, the S1, the zone 1 is basically the S1 vertebral body and the cephalad margins of the sacral ala. Zone 2 is the caudal part of the sacrum. Zone 3 is the ilium. And again, the implant construct increases as we proceed from zone 1 to zone 3, and any implant that traverses more than one zone, and especially ones that go from zone 1 to zone 3, are considered to be the strongest type of implants in these cases. Now, there have been several attempts at historically at getting a good construct across the lumbosacral junction and across the sacroiliac joint. I'll not be going into too much of details, but what options we have available today is these. One is the sacral screw. We know that sacral tricortical pedicle screw. I'll not be discussing too much, and especially it is better to have a slightly lower inferior point, in order to get the tricortical purchase right across to the promontory when we are putting the S1 tricortical pedicle screw. S2 LR and S2 short screw. S2 short screw is very used. S1 and S2 LR screws are something that are also used. And then comes the screws that actually go into the ilium, that is iliac screw, Amrita technique and S2 AI techniques. So I'll just be discussing about the other techniques, that is S1 LR screw. And as we know, an S1 LR screw can be used either as an alternative or as an adjunct to S1 pedicle screw. And there is a slight difference in the technique when we are using it either as an alternative or as an adjunct. So when we use it as an alternative to S1 pedicle screw, the entry point, as you can see there, will almost remain the same, but the direction that it goes towards the promontory, whereas here it goes slightly inferior to the promontory, to the most prominent part of the sacral ala, anteriorly, to increase the length of the screw and to go more anterior to the LS pivot. But the direction is almost similar to the contralateral S1 pedicle screw. You have a medial angulation here, but here you have a lateral angulation that has to go there. Now, in many cases, the LS, what we call the orientation of the SI joint, which can be studied preoperatively in an MRI or even intraoperatively just by passing a small LP needle into the SI joint, will give us the exact direction of the sacral ala, and that will also help us to assess how much laterally we can go to increase the length of an S1 or an S2 LR screw. So S1 LR screw, when it is used in adjunct to S1 screw, it is important to note that the position of the S1 screw entry point increases, or it goes slightly up higher, whereas the S1 LR screw is started a little bit more inferiorly and goes in the direction opposite to that of the S1 screw in the coronal plane, as we can see in these images there. So that's a small thing that we have to take care. Again, the lateral angulation will be seen. So this was the point that I was telling. A small needle, an LP needle, is usually what you can use, which is positioned inside the SIJ, will give you a clear orientation about how the lateral angulation of the ala is there, and that will help us to guide the lateral angulation for the S1 or an S2 LR screw as well. The S2 LR screw is almost similar. It can be used as an adjunct to S1 pedicle screw or to an S1 LR screw. And again, the entry point is, as it's shown here, is between the S1 and S2 posterior foramen, almost similar to that of an S2 AI screw, as we are going to discuss later. And it is goes not as much laterally directed. It's around 25 to 30 degrees laterally oriented. But again, this angle can change based on the orientation of the SI joint. Now, this is something that it has to go all the way to the anterolateral corner of the ala. And the more longer it is, the better it is, as I was pointing that out. And also, if it is possible to attain a bicortical purchase, it's always better. It increases the screw pull-out strength, especially in an S2 LR screw, because otherwise it can become a very short screw. Now, these LR screws have several advantages and disadvantages, because these are very easy, and as you can see there, it can be easily connected to a superior construct that is there. compared to an S2 AI screw, the advantages was that it has a lower profile, it is faster, it has reduced blood loss, though it may not be as strong as an S2 AI screw. But in cases where you don't actually need to cross the SI joint, this is actually a suitable alternative when that much of a stronger screw is not required, but you need something that is required as an adjunct to an S1 pedicle screw, which is considered to be a little weak in those particular cases. The main advantage is preservation of the sacroiliac joint. Of course, if bicortical purchase or the lateral angulation is incorrect, it may become a very short screw, and of course, it will become a very weak screw in these cases. So that is something that we have to take care. And the more medial it comes, again, the chances of a neurovascular injury to the structures that is anterior to the sacrum is something that also can increase if we do that. Now, among the screws that come into the ilium or, actually into the pelvis there. So in those cases, iliac screws were the one that were traditionally used. It was a very popular screw that was used. And usually to put in an iliac screw, we used to target the most prominent part of the PSIS, go 2 centimeters down, 2 centimeters up, and then that used to be the entry point. And because it used to be buried inside, and from there you need to angle towards the anterior inferior iliac spine on an AP-C-arm view, or sometimes you can even palpate the greater trochanter and target it slightly superior to that. So that is something that we used to do that. But however, the iliac screw, the disadvantage is that because it is positioned or the starting point is very, very superficial, the screw head becomes very superficial, and that can lead to sometimes an implant prominence, and that can lead to a lot of discomfort for the patient, especially if the patient is a lean patient. And that is why the traditional technique also recommends that there has to be an osteotomy in the PSIS in order to bury the screw head under the bony outline, and so that the screw prominence is not beyond the bony prominence. And that is why in these cases, once it becomes buried into the bone, it becomes quite lateral. The offset is there compared to the S1 screw or the screws that are there in the lumbar region. And that is why we need to use a lateral connector or an offset connector in order to connect this particular screw to the construct that is in the lumbosacral region. Now, the alternative is again a subcrestal iliac screw, which doesn't get buried inside, it stays outside, but the screw is actually below the prominence of the ilium bone. The posterior cortex is not removed. The entry point is just at the same entry point as discussed before, but actually there is a small, we can make one small hole there in order to bury the screw head to a certain extent, and that also can reduce the amount of implant prominence in these cases. Amrita technique is something that was designed by the Amrita Institute, Professor Menon and his colleagues, in order to subvert this kind of problems, and also to use these screws whenever there is whenever sacrectomies also are being done. So here the advantage is that there are no iliac connectors. It does not require any special, and it's almost as strong as the S2I screws. You make a small osteotomy in the posterior superior iliac spine on the superior aspect to make the posterior part of the PSIS in level with the ala over there, so that it is flush with the ala, and from there you target 2 screws, one going into the standard iliac screw trajectory, and the one that is going in towards the crest, almost like a crest screw there. And these 2 heads will come almost perpendicular to each other, and they will be just next to each other, so that a single coronal bend in the screw is required. A single around 40-degree bend is required in order to position it from an S1 entry point, from an S1 screw head into these 2 screws. And this considered is one of the strongest fixation into the pelvis, because these screws are divergent and the pull-out strength is virtually limitless in these cases, because both these screws are going in opposite directions. S2 AI screw, of course, is considered a very common technique that is used now. It is a superior alternative to iliac screw or an S2 LR screw, and perhaps in present day scenario, one of the, it is more commonly used than any other screws that we have discussed till now. And the technique is quite simple. It comes in line with your S1 screw between the S1 S2 foramen, just medial to the lateral sacral crest. And from there, you target around 40-degree angulation laterally and 20 to 30 superiorly. But this again can change there based on the morphology of the pelvis. These are not standard. This is just a rough guide. We need to study the preoperative morphologies. Sometimes these pelvises may be dysmorphic. Sometimes there is a lot of variation between males and females as well as to the direction of these particular screws. So that is something that can be determined based on preoperative images. Now, as I was mentioning, these are stronger, longer. There is no need to expose the PSIS. It requires less exposure as compared to putting in an iliac screw. The screw, because it is buried almost, it is 2 centimeters inside the entry point for an iliac screw. So that is why it is less prominent. Because it is in line with the superior screws, the upper screws, there are no connectors that are required. And studies have also shown that the chances of complications, implant loosening, or post-operative pain is less when S2AI screws are used as compared to an iliac screw. So this is something that is there, the exposure that is required to put in these kind of screws, whether it is an iliac screw or an S2AI screw. So this is the subcrestal iliac screw. As you can see there, it is buried under the bone here. But this is the amount of exposure that is required. And as you can see, it is quite extensive. And so that is why what has come nowadays is minimally invasive iliac fixations, which actually decrease the amount of exposure that is required. You can have 2 paramedian incisions or a single median incision that I'm going to talk about. So this is, again, it can be done either with a 2D fluoro navigation, or if 3D navigation is available, it can really help us in targeting or achieving a very good purchase and getting a good direction. And as you can see, the entry point on the skin for both these iliacs, both these S2I screws almost comes in the midline. So this can be done, as I was mentioning earlier, with a single midline incision for divergent screws, which go towards either side from a single midline incision, and then towards the either of the iliac screw, as it is described here in one of our papers. Compared to the other types of screw, there is a single, the other type of fixation that we have to consider is an SI fixation, that is an iliosacral screw, which doesn't go into the lumbar region. It's only across the SI joint, and it is used for sacral body fractures, SI dislocation, and iliac wing SI disruption injuries, or refractory SI pain or sacroiliitis. Usually in these cases also it is used. The technique is quite simple. Again, we need to get a good image so that the ICD is parallel to each other. There is a single ICD line, and the target area of the S1 bone is there. We need to consider the inlet and outlet views. So this is something that I'm not going to go too much into the detail, and something that we need to have good fluoroscopic images to target these screws. And the entry point will be just below the ICD line, as well as anterior to the posterior sacral line, as close as it is possible. And from there, it can go straight down or slightly more anterior, depending upon what pathology we are treating. Usually for an SI joint pathology, it is better to be perpendicular to the joint, whereas in treating sacral bones, where we need some kind of a sacral bone fractures, where we need some kind of a compression, it is better to go across. If the morphology of the sacrum allows, it is better to go across all the way to the contralateral ilium. And as I was mentioning, this can be done under navigation guidance. 1 to 2 screws can be easily placed into the S1, as well as, if required, into the S2 as well. And this can be done, as I was mentioning, along in either as a standalone procedure or in conjunction with a superior or an upper L5 or S1 constructs as well. So I'll go into the indications and what are the case examples. So basically, the indications for pelvic fixation can be divided into 2 main categories. One is where there is an intact sacrum or an L5S1 segment, and there we are going into the pelvis or ilium to circumvent the significantly increased biomechanical stresses that we are going to expect post-operatively. The other part, the second category, is where there is a destruction of S1 body or an end plate of the end plate of S1, or where there is a destruction of SI joint itself, which is responsible for either a poor screw into the S1 or responsible for instability across the sacrum itself. So coming to the first category, the most common indication is long fusions to the sacrum. And as we know, though it is said that it has to be done if it is more than 4 levels, that is anything that goes beyond L2. But we all know that many times we do L2 to S1 fusions, and it's not necessary that always in these cases we go to the pelvis, but it is strongly recommended that whenever we extend the fusion superior, that is across the thoracolumbar junction, maybe we go to D12 or D10, depending upon the case, it is always better inferiorly to extend to the pelvis, because the S1 screw has a higher load at that point of time, as I was discussing in the initial slides. In cases where there is osteoporosis, poor S1 mold, or there is an oblique takeoff at L5 S1, as is seen in this case, it is better to go into the junction, into the pelvis, into the ilium. So the second category where we do this is a high grade or a dysplastic spondylolisthesis. And as you can see there, whenever there is a poor S1 body because of either dysplasia, because of rounding, or because you would already do an osteotomy in order to correct the S1 rounding, S1 dome rounding, in those cases, it is better to actually go, because your S1 screw purchase is less. This is a high grade dysplastic spondy, and it's better to go to the pelvis in these particular cases. Now, again, this is one case that we encountered, very looks to be a routine L5S1 listhesis, right? So again, but you see in the standing position, there is a lot of instability. It's almost progressing from grade 0 in the supine position to grade 2, almost borderline grade 2, grade 3 in this case in a standing X-ray. So we thought that, okay, it's doing a single level augmented fixation, MIS is sufficient probably, and that is going to hold. But the patient unfortunately came back even 3 months later. And these are the cases where we expect significantly higher biomechanical stretches. We did not manage, which was not responding to any type of conservative management, because of course it's an early implant failure. And these are also cases where a patient is also very obese, sorry for the poor quality, where iliopelvic fixation and revision surgery was done in order to go into the pelvis and one level above. Now, the second category where there is a destruction of S1 body or end plate or SIJ pathology itself, these can be actually multiple categories. It can be traumatic, which is of course one of the more commonly seen things. This is a simple zone 2 sacral fracture, which actually can be managed by a single unilateral, iliosacral screw or an SI joint screw. So as you can see there, so this is sufficient to stabilize these kind of fractures and allow it to heal. In cases where the pathology extends into either the S1 end plate, or there is an L5 pars fracture or an L5-S1 disc disruption also, as seen in this young male with a high velocity injury. In these cases, it is important. This patient also has a lower, type 2 fracture at the transverse fracture of the sacrum. So this again, it has to be managed with a lumbopelvic fixation. Again, can be done as minimally invasive in these particular cases. Even complex cases can be managed, with MIS iliopelvic fixation, especially in these cases where there is a polytrauma. You need a very short surgery. You don't have to have a very morbid surgery for these patients. Again, it is possible to do a lumbopelvic as well as put in an iliac screw percutaneously to make the surgery faster, as well as minimize the amount of iatrogenic injury in these cases where there is a polytrauma as already. Again, in complex cases where even simple lumbosacral fixation with bilateral SI screws also can be placed depending upon the type of stabilization that is required, whether it's a unilateral or a bilateral fracture. Again, this entire thing can be done minimally invasive. Neoplastic etiologies, I see that there is a case that we are going to discuss. I'm not going to do that too much in detail. So sacral tumors are something that is required. Even cases where there is a destruction of an L5 as well as S1 vertebral bodies, as seen in these cases, it is possible to put in cases. This is the Amrita technique. You can use in 2 screws perpendicular to each other, and they go in opposite direction, and it can be combined, or it can be fixed to the lumbar construct as well. Infective inflammatory pathologies involving L5-S1 junction or an S1 superior body, also sometimes it is useful to go into the pelvis. As we can see in these particular cases, we can do a combined stage posterior anterior approaches, or a single stage posterior approach, as we can see there is a significant collapse, significant loss of stability at L5-S1, almost hardly any disc space left in that particular place. This can be restored, and also because the S1 construct is poor, we can actually go into the pelvis in order to increase the hold of these cases. Pseudo-orthosis or revision surgery for prior surgeries that have been done at L5-S1 junction. As you can see there, this again, we underestimated the amount of biomechanical stress. This patient has a multi-level listhesis, significant loss of lumbar lordosis, was treated with just 3-level OLIF, but came back with an early failure, early collapse, vertebral body fractures, and obviously this patient had to be revised with a D10 to pelvis fixation again, which was done as MIS in this particular case. So the take-home message from my side here is it's important to be aware of, when we are considering lumbopelvic fixation, of the basic concepts, the available options that we have, and what are the indications of pelvic fixation. Now, minimally invasive techniques, as I've shown, can minimize the morbidity associated with pelvic fixation. Thank you so much.
Thank you very much, Dr. Umesh, for the very comprehensive lecture on sacropelvic fixation. Are there any questions? We are running a little bit behind time, so I'll just allow 2 questions from the audience. Yeah.
I can ask a question.
Can,
Umesh, thank you
yeah.
very much. It was a wonderful presentation with dozens of pictures, and that shows the volume that you are doing.
Thank you so much, sir. Thank you.
What do you think about adding interbody fusion? Does it enhances the stability of the lumbosacral or lumbopelvic fixation? And the second question is, by using iliac screw or other iliac screw, we stabilize the SI joint. So what is the impact on the quality of life of the patient when we stabilize the SI joint?
Well, Professor, thank you so much. And the first question, definitely yes, adding an interbody construct at L5-S1 improves the quality of the construct. And many times when we do a simple L5-S1, as I have also shown in the example, we don't have to go into the pelvis many times. And only when the construct is more than 4 levels, according to literature. But I do a lumbopelvic fixation only if the construct extends into the pelvis, into the thoracic spine. So only then lower down we go into the pelvis. So, but adding an L5-S1 construct or an interbody fusion is not going to take away the torsional force of a long construct if we don't go into the pelvis. So the interbody work at L5-S1 is going to be helpful to avoid going into the pelvis only for shorter construct. But for a longer construct, I think it is still necessary, despite doing an L5-S1 interbody work, to extend the construct into the pelvis. So that is the first question. The second question is the quality of life after SI joint fusions. Well, in the absence of a prior pathology at SI joint, now obviously these patients do have certain limitations in their activity after we stabilize the SI joint. These are cases where there is a long construct or where prior SI joint involvement, prior SI joint pain was not there. So in these cases, definitely, yes, there is a significant difference in patients who undergo fixation only to the sacrum vis-a-vis patients who undergo fixation to the SI joint, S2IS screws. But again, literature in this particular case has been very conflicting. Long constructs which spare the SI joint, patients usually also develop SI joint pain post-operatively. And in these cases, in these cases, long constructs, it is always better to go to the SI joint because SI joint stabilization actually increases the stability of the construct plus decreases the incidence of post-operative SI joint dysfunction in these patients. So there is a mixed opinion about how this has to be dealt with. I think the primary thing that we need to decide is based on the particular case, the amount of stability of the construct that we need, and the length of the construct that we are dealing with.
Thank you very much, Dr. Umesh. Dr. Tanaka, one last question.
Yes. Thank you for a wonderful lecture. I have a question
Thank you,
about
Professor.
about pelvic anchor. So you mentioned about S2AI screw. In Japan, 98% doctor choose SAI screw instead of iliac screw, you already have navigation, but you sometimes use iliac screw. So what's the merit for iliac screw over S2AI screw?
Well,
There is no
yeah,
merit to
there
choose
is no merit. Yeah.
iliac screw.
So I completely agree with you. The image that I showed was not actually of an iliac screw. That was just a planning for an iliac screw. But yes, we have used iliac screws in the beginning when we did not have navigation, because we felt that it was easier to identify. When we are doing MIS, it was easier to identify the entry point for an iliac screw with an MIS technique as compared to identifying an S2 AI entry point with minimally invasive incisions with mini open or MIS technique. But after the advent of 3D navigation, now routinely we also use S2 AI screws. Only in cases where there is a sacrectomy, where there is a sacral pathology, where the sacrum is not available to put in an S2A screw, for example, as I was mentioning, after a sacrectomy, either we can go for a iliac screw in those cases, or we can go for an Amrita technique.
As you know, the inventor is a Kebesh, so he is an Egyptian American. So he put the screw in the C-arm. Of course, even for C-arm, if you see the teardrop view, it's very easy to put the screw. Of course, if they have a navigation, much more easy. But even though the C-arm, this technique is relatively simple, I think. Thank you.
Thank you.
Okay, thank you very much, everyone, for your comments and for your questions. Now, I would like to pass to my colleague, Dr. Vijay, to continue the moderation. Vijay, all yours. Is Vijay around? If not, we can continue. The next topic is a discussion session or case presentation. So I would like to invite Dr. Nugroho to present the first case on thoracolumbar fixation. Nugroho, please go ahead.
Thank you, Professor. I will share my screen now. And everyone see? Thank you, my mentor, Professor Tanaka, Professor Chris, and also Professor Ronald. I'm sharing some of my old cases. This is a 52 years old factory owner, fall from the height, no loss of conscious, and then heavy smoker, and he's a diabetic. There's a numbness and weakening in both of his leg, injury on our arm and wrist, and hemodynamically stable. This is the physical examination. And then the motoric function is a little bit low. And then this is the X-ray. We can see there's only minor compression in the thoracic 12. So this is the C-arm. At the MRI finding, we can see there's a compression, and then a little bit compression in the thoracic 12, and then also there's a bulging on the L4, L5 patient. So with the Tilk score, there's a 4, and then with our spine classification is a incomplete burst, and then actually the management, this patient is about 2 months after I go to Professor Tanaka in Japan in 2019, and then the management of this patient, is it conservative, open long construct, open short segment, and then MIS, or we do a kyphoplasty or decompression or not. using post-op brace or not. And then at the time, I do MIS from thoracal 10 and to L1, and then we do
Dr. Nugroho, maybe we leave this after the discussion with the panel.
Okay.
Yeah, we'll stop here first. Okay, so now we open the discussion to the panel of experts as to how would we manage this case.
Okay. Okay. Can I ask Professor Tanaka or?
Yes.
Okay. For this patient.
Let's go back to the MRI. This is, as you said, A31. So not so severe, not severe. So even though A3, sometimes conservative treatment can work. Sometimes. But neurologically instability they have. So I choose MIS technique, one above, one below. This is not so, the bone quality is not so bad. So one above, one below, and maybe intermediate screw as well. Percutaneous reduction, in my opinion. But conservative can work.
Okay. Is there any suggestion for Dr. Umesh?
Yeah. So I agree. I think this. I think we'll plan it for a conservative management in the beginning stages. So do we have an X-ray for this? So we had an X-ray, right? So usually in these cases, what we do, what I usually follow, is we get a delayed X-ray. So this is an immediate post-injury X-ray, and there is hardly 10% collapse. There is mild retropertial. It's not a significant one. No neurological compromise. So usually we manage this patient conservatively, allow limited activity, and probably get a standing X-ray after 2 weeks. And see for if there is any progression. Usually in these cases, if there is no progression, the pain comes down, the patient mobility improves, and there is no collapse, progressive collapse that is happening. I think these things are going to heal on their own. And I also agree with Professor Tanaka, if surgery is required in these cases, if there is a collapse, usually I would just do one up, one down with an index screw bilaterally. These pedicles usually will take an index screw, and that should serve the purpose in this case.
Yeah.
Any
For
comment?
me, for me, Dr. Nugroho, I think over the years, I tend to be conservative in this type of patients. Patients do away with having to live comfortably without doing any surgical procedure. I think you just have to closely follow up this patient. But I agree, if there's a need for it to undergo surgery down the road, maybe, but most likely you don't need that anymore. Thank you.
Thank you very much. So this is 6 years ago, and then I do, because I learned MIS from the Professor Tanaka, and I want to try it in my patient. And then after that, the question are, we don't have we don't have mono screws, so it's not so good for the reduction of the fracture. And then is it my question to the mentor is it safe to stop only for the short segment, even in the thoracolumbar junction? Sometimes 6 years ago I have doubt, so I put one more screw up to enhance the construct. And then is it should now is the after the fracture is healed, should the MIS should be removed or not? And what are the fracture for the patient? Is there a comment from Professor Chris, maybe? Or
Yeah, but we ask the panel first. Can you show your post-operative radiographs, AP and lateral?
Chris, can I answer this?
Yeah, sure.
Yeah.
I'll let the panelists answer first.
Yeah.
Yeah.
With regards to the question number 2, I also come across with trying to remove implants. So there are questions with regards to functionality and pain scores with regards to trying to remove the implants. Those are the two main questions and the two advantages of removing it. Now, they found out that if you remove the implants, it generally leads to a better pain scores and improve in the functional scores as well. So therefore, there's really a good removing the implants may be a good option, even if you don't decide to fuse the spine, for example, if you do an MIS. But the thing here is that the best indication for removing the implants is actually best for younger individuals, young male patients with good bone stock. But I think that's not a bad decision if you decide to remove it, Nugroho.
Okay. Thank you, Professor Rona. Because this patient is 5 years, they come to my new home, and then he want to remove it, and nobody in the Borneo wants to remove the implant. So he come back to me after 5 years to have this removed. That's why I asked to all of the mentors here, what is the age? If young, it's better to have removed, or what is the cut-off point? 40, 30, or 20 years, or how about that? So
The study talks about removing implants for younger patients, but the better question is when to remove it. I have come across a study telling that you can actually remove the implants if it's beyond 12 months. So again, that is the recommendation if you decide to remove it. Thank you.
thank you, Professor. And
So I have an opinion. So if you wait 5 years, already posterior part is fused. So in Japan, we remove before 1 year, 1 year follow-up. And if it's not the fused, the implant will break in the end. So 5 years, it's not the breakage of the rod. This means posterior part will be fused, already fused.
thank you, Professor. Okay. One more patient. The complaint is 30 years old man, cannot walk far. They have back pain. The pain also from back to the both of his leg. They have a TB drugs 6 months. And then there's a gibbous and deformity. Also midline tenderness, and there's a weakness. So the motoric is slight low. There's a history of paraplegic 6 months ago, but now he can walk again. And then this is the X-ray. There's a TB of the spine with the apex. The gibbous is in the thoracic 12. And then so this is the MRI. Yes, after 6 months TB drugs, they're still like pus also. So my resolution for that time is open reduction and decompression, and then using a pedicle screw fixation in thoracal 9, 10, and 1 and 2. But all we can see, there's a gap here in the anterior part of the thoracic 12 and 11. Is there any comment for Professor, all of the mentor?
I can comment. This is exactly like my earlier question, the anterior column reconstruction. If the anterior column is deficient and is not properly reconstructed, your posterior instrumentation is not going to last for a long time. In this case, you have nicely reduced the deformity, but there is a big gap anteriorly. And I think there has to be a cage anteriorly. The best would be to do it from the posterior in the same approach that you are doing, and put a cage that can stabilize anteriorly, and then your screws are already you are doing. So that will do a good job, would prevent the deformity from progressing, and would maintain the sagittal balance as such. But if you keep it like this, I think it's going to break.
Okay. Yes, sir. And that moment, we don't prepare the cage first, and then the patient is a francal excellent, so we are afraid of putting cage in from the posterior, and then treatment later we do anterior diaphragma, as the Professor Ronald said, to do to put some cage there, and then this is the post-op. But what I want to ask is about when it's safe to do a shortening at the thoracolumbar junction, so we don't have to put a bigger cage. And then francal excellent patient is safer to put cage direct from the posterior or other approach, or anterior, or maybe in the second stage or other day. And is the bigger anterior corpectomy cage better, or small one with bone graft is better? Can I have opinion from my mentor?
Nugroho, are you using intraoperative neuromonitoring here?
No, I don't have intra monitoring.
Yeah, I think with regards to the first two questions, it helps a lot when you do IONM here. You can be a bit more aggressive with regards to even correction of the deformity. I think nowadays I agree with Professor Arif that you can actually put the cage from posterior. So you just somehow in some rare occasion, I even ended up with sacrificing a nerve root in the thoracic level because it does not affect the lower extremity. So by doing so, you can put a bigger cage from posterior going anterior as well. So the other thing is that you can somehow retract the nerve root if you need to. So yeah, I think it helps if you are familiar with IONM. Thank you.
Yeah, thank you, Professor.
Is that okay? I'm sorry to say, Dr. Tangente, in Japan, we always use mini corpectomy from anterior. So in India, maybe in your country, posterior, all reject posterior part and then make unstable and then reconstruct. It doesn't make any sense for me because posterior part is intact. So we should reconstruct just anterior part. Why you destroy whole posterior part and then put the cage from posterior? India always do this, but Japan never do. MIS corpectomy, very less minimally invasive technique, 1 hour or something, and very few blood loss. And for TB spine, the implant, metal is okay. There is a paper from Japan. So why you choose posterior? Posterior?
I think
It's not a good idea.
I think you have
Mm.
to actually analyze the cases not as a general statement, because you need to review the history, for example, the chronicity of the involvement and the degree of kyphosis. I do agree that yes, in some cases, because we used to do it anteriorly in the early years, for cases like this, we can actually do it anteriorly before. But I think somehow a 360 construct is also a good option. But I don't argue with you that in Japan it makes sense. But the point here is that if you have a very chronic case of deformity, somehow you also need to do some posterior release. So in other words, you probably be able to correct some anteriorly, but you probably will achieve a better correction if you release it posterior. That's our opinion, Professor. Thank you.
Yeah, I can comment on it as well. I think Professor Tanaka, it also depends on the degree of the deformity and the bone quality that we have. So it varies from patient to patient. In a case like this, with about 60 degrees of deformity or more than that, correcting or trying to correct it only from the anterior would be very difficult. Restoring the lordosis in that region would be next to impossible. And then if you put a cage anteriorly only and do not address posteriorly, that cage is going to subside into the bone and the deformity is going to progress and the cage is going to displace. So it's safer to do it both column, both anterior and posterior. Now it depends on your expertise. You can do both from the posterior, that is the best. But if you cannot do that, you can do anterior and posterior. But if you do not add posterior to such severe deformity, I think correction the deformity would be difficult. And then maintaining that deformity would also be very difficult because there would be a lot of stresses on the cage.
Thank you, Professor Arif.
Okay,
Thank
of
you very
course,
much.
Okay, I do a lot of deformity. I'm a deformity guy. For fixed deformity, of course, posterior VCR. But this is already correct, and this is infection, right? That's why I said I consider this situation, not the general discussion. Of course, I do posterior PSO as well.
Thank you very much, everyone, for the very interesting discussion. Thank you, Nugroho, for presenting two interesting cases. So now we proceed to the next case presentation. The next case will be delivered by Dr. Jun Tan Hao. So he's an associate consultant at the Department of Orthopaedic Surgery, Division of Spine Surgery at both NUH and Ng Teng Fong General Hospital. So without further delay, Dr. Tan, can you please present the case?
Thank you very much. Thank you very much for APSS committee for the invitation. It is my great honor to be here today. So I'm Jun Hao from NUH National University Hospital from Singapore. And today I am presenting this 75-year-old gentleman who was a pre-morbidly ambulant without any walking aids. He has two metastatic, or rather two tumor history. The first one being a metastatic high-grade ureteric urothelial carcinoma. It was first detected in 2019. At that time, primary resection was performed, but unfortunately had two recurrences, first in 2021 and subsequently in 2023. Of course, he have had chemotherapy as well as 2 rounds of a conventional radiotherapy in 2022 and 2024. He also had a lung adenocarcinoma, which was stage 3, and that was primarily resected in 2019 as well. So he presented with a right lateral thigh pain, lateral calf pain, and dorsal on the foot pain in the L5 distribution on the right side for 4 months duration when he was first referred to me. It was progressively worsening. He had numbness over the right L5 distribution as well, particularly over the right lateral calf. He himself did not note any weakness, and there was no bowel or urinary incontinence. On physical examination, while he was a very cachectic individual, he was only 49 kg, BMI was 17.7, and when I first saw him in the ward, he was unable to sit up or stand up for any prolonged period of time, indicating that there was instability going on. On neurological examination, while there was a very mild weakness of the right L5 myotome at MRC grade 4 with some numbness over the lateral calf, but otherwise he was fairly intact in the other myotomes. So this was his sagittal MRI scan. Let me go through it, the individual axial cuts. Firstly, we have a pathological fracture of L2, but that was mild. There was less than 50% collapse, and the sin score for this was stable at score 9. But at the L4, there was again a pathological fracture with, as you can see, involvement of the right pedicle, and that was causing both a foraminal stenosis as well as lateral recess stenosis, causing his right L5 radiculopathy. And the sin score calculated at this level was 12. Also, interestingly, when I was going through his scans, I noticed that there was this homogeneous enhancement of bilateral sacral ala, S1 ala. However, on the contrasted view, there was no signs of tumor. So I discussed this with the radiologist, and they told me that this was likely due to the radiotherapy. So this was fatty marrow conversion of the cancellous bone, and hence causing this appearance. So there was actually maybe some tumor of the superior end plate of S1. You can see that on the sagittal view on the left side of the screen, but largely the homogeneous enhancement was mainly due to fatty marrow conversion. These were the CT scans. As I mentioned earlier, you can see that this is almost like an empty box at the bilateral sacral ala, as well as the S1 superior end plate. And on the L4 vertebrae, you can see that the right pedicle, similar to what we saw on the MRI scan, shows that there was involvement of the right pedicle with tumor cells. So at this point in time, when he was referred to me, he had 4 months of pain. And in terms of the treatment he has received thus far, he was already on follow-up with the what I mean, very well known to the medical oncologist, the radiotherapist, and he was on palliative chemotherapy. In terms of radio-oncology wise, they have seen him, and they felt that further radiotherapy may not be useful because this gentleman, if you remember, had already received 2 separate instances of radiotherapy, and from past experiences, they felt that his urothelial carcinoma was fairly radio resistant. He was also seen by the pain team, and in terms of analgesia, he was maximally optimized, including giving high dose opioids, but there was still suboptimal control of pain. And when I discussed it at a multidisciplinary meeting, the medical oncologist mentioned that he had a prognosis of 12 months. And when we scored him according to the Tokahashi score, that also showed that he had a prognosis of 12 months. So the problem list for this patient was number one, he had a L4 pathological fracture with right lateral recess and right foraminal stenosis with a compression of right L4 exiting nerve root and the traversing L5 nerve root. He had a L2 pathological fracture, although that was stable. This is a very cachectic patient. BMI was 17.7, and he has a metastatic urothelial carcinoma with a prognosis of 12 months. So at this point in time, I'd like to invite any opinions to the various professors regarding number one, perhaps will you offer surgery to this patient? And if so, what would your surgical options be, especially in terms of UIV and LIV?
Thank you very much, Jun Hao, for the very crystal clear presentation. So now I would like to open the discussion to the faculty here. Any comments, Dr. Tanaka?
First, we use a lot of opioid, and then even though patient take opioid, the pain is so severe. So I do MIS packed and pedicle screw from maybe T11 to pelvis. Pelvis is SCI screw because the patient would like to sit. If the pain is so severe, so patient bedridden is not a good idea. But first, you should try a lot of opioid. And then this is effective. You don't have to do surgery. This is not a good candidate for surgery.
Ronald, any comments?
Yeah, can I see the scanogram going up further, please?
Is this the one, Professor, you're looking for? So he had
yeah,
a
further
metastasis
up.
to the, oh, I'm sorry, I didn't have the slides for further up. He had some sporadic, some levels of metastasis in the mid and upper thoracic region, but those were fairly stable. So no further collapses. So the 2 collapse or pathological fracture levels were at L2 and L4.
Yeah, I think that is a very essential part in the decision making.
Yep.
So the other is that you have a very cachectic patient, and then the problem with Tokahashi score is that a score of 12 is somehow questionable. The sensitivity and the specificity of the Tokahashi score is really not very reliable. I think the basic thing that you need to also consider with regards to surgical decision making is the frailty index. So you have to look at the overall frailty status of the patient with regards to this issue. Now, do not just focus on the pathology in the lumbar spine, because we as a surgeon are somehow fixated with doing surgery. So the message is that you have to involve everyone. For example, do you have a CT scan of the chest? Do you have some issues with the chest here? So is there some lytic lesion or sorry, is there some involvement of the pulmonary side here? Yes. So those are the issues that you need to evaluate as a general. So the problem in my early years is that I was really fixated with doing surgery. The other thing is that you don't also need to underestimate the value of anti-resorptive agents, because in certain situations it actually helps stabilize the spine over time, over 12 months. If I need to do surgery here, I think there's a role of trying to do endoscopic decompression to just address that particular problem. Thank you.
Dr. Umesh?
So I have, before we go to Umesh, I have a point to make here. As Dr. Jun Tan Hao said, this very cachexic patients are nutritionally very deficient. I'll be a little skeptical to go very long. If you have a good interventional radiologist, I think we have some experience about doing a percutaneous radio ablation of this metastasis and just augment it with the cement. That is what we do. So I guess two vertebrae are mainly primarily which is of concern at this point of time, L4 and L2. So I guess we just can do L2 cement augmentation for radio frequency ablation and cementing, I think. And if still pain persists, then as Dr. Ronald says, maybe endoscopic decompression. I wouldn't want to offer too much to this patient. Umesh, would you agree, or you have a different opinion?
Definitely, surgery is a very risky option in this particular case, and especially a long segment fusion is going to be very risky. And considering that patient has a disseminated disease and the best prognosis is around 12 months, so we need to reconsider whether we need to subject the patient to such a long procedure. And I completely agree. The less it is better for this particular patient. If it can be managed by medical management, or if it is just a radicular pain that we are concerned about, whether we can do any percutaneous procedures. Otherwise, I will also be very, very open to just doing a minimally invasive, either tubular or I would prefer tubular decompression, a lateral recess decompression, and freeing the nerve root and probably decompressing the tumor to a certain extent without compromising too much on the stability. Rather than going too long in these particular cases.
I have a question to the mentors. So this is a candidate for decompression because this is just one root compromised, and then this is a terminal stage. I can understand this causes myelopathy or something, thoracic level. Sometimes we need decompression. But this is just one root. L4 nerve root is compromised. Why you do the endoscopic decompression for this patient? In Japan, never. Just one muscle is not moving. It's not so important for the patient. Why?
Professor Tanaka, the reason why we want to do decompression has been told in your sentence itself.
Yes, never do.
Because there is only one root involvement and there is only one level involvement. So why not we do just a decompression rather than a long segment?
Dr. Tanaka, is very, very painful.
Yeah, so the point here is, I guess, we just have to give relatively pain-free survival to this patient as much as we can give, So doing less and just, try to manage pain. In fact, I would even consider giving a lot of root blocks, or I may involve my pain physician also to put epidural catheters to manage pain, But, as Umesh and everybody said, I guess our approach would be to do as minimum as possible so that, we can give relatively comfortable rest of the 12 months to this patient.
Yeah, I totally agree that a single is a radicular compression has less urgency compared to a cord compression. But of course, the key is the quality of life and the pain relief. I'm sure Jun Hao and his team has tried conservative treatment or even pain procedures for this case. Let's say if it doesn't work, then Dr. Tanaka, what would you do? How would you decompress? Or how would you decompress and stabilize this patient?
I have a lot of experience to decompress this kind of tumor, but if the chemo is not effective, it's almost within 2 or 3 weeks later, the tumor is engrossed and then compressed again. So the main pain is from vertebral fracture, and patient would like to sit or stand. Not the pain is killed by a painkiller like opioid. So, but the mechanical pain is very difficult too. So that's why sometimes we do PPS, percutaneous pedicular fixation. So not so severe. It's a kind of minimally invasive surgery, but first we think about conservative.
Okay, maybe Jun Hao, you can show us what did you do for this case?
Yeah, thank you everyone. Thank you for all the mentors for your suggestions. So just maybe a few points regarding what happened in the interim, because I actually sat on this patient for almost a week because of all the multidisciplinary discussions that I had with the oncologist, with the radiotherapist. So basically during that week, I used the time to try a further conservative treatment. So what I did actually was I treated with him with a brace as well, because in my mind, the two issues that I had with him was number one, instability pain. So he was unable to sit and stand for a prolonged period of time. Remembering that this was essentially a ambulant, independent gentleman prior to having this pathological fracture. That's number one, mechanical instability pain. And secondly, he also had a right L5 radiculopathy, and which, despite maximum usage and optimization of opioids and analgesias, he was unable to be controlled optimally. So even with the brace and with the opioids, he was not getting better in terms of the pain. So I held multiple discussions with him and the family. And essentially, he decided that even though he knew he had 12 months left in terms of the prognosis, he still wanted to get back some sort of a function, even though he understands that this is a palliative procedure. So basically what I did for him was a L1 to pelvis posterior instrumentation. So this was, I'm going to show the final x-rays in 2 slides, but this is what I did intraoperatively to show you the II's images. And basically I did a right pediculectomy and separation surgery to free up the entire L4 and L5 nerve root, and I did this open. The reason for this was because I wanted to treat both the mechanical instability pain as well as the right L5 radiculopathy in the same setting. In terms of the choice of UIV and LIV wise, the reason why I went down to pelvis, as I shown earlier, was because I did not trust the S1 bony purchase because of the fatty marrow conversion, and essentially the S1 bilateral ala was essentially a empty box with no cancellous bone at all, and the cortices, as you can see, was thin. So I went in terms of LIV wise, I chose all the way down to pelvis. In UIV wise, actually, I had cemented screws on standby, fenestrated screws on standby, and actually I was fully prepared to cement the UIV, and I was considering between T12 and L1, remembering that L2 had a pathological fracture. I did this case under O-arm, and when I spinned, after I spinned and looked under the O-arm guidance, I noted that the L2 actually on the right side allowed for a insertion of pedicle screw with some minimum tumor. So the tumor was mainly on the left side. So on the right side, it managed to insert a index screw at the level of the L2 pathological fracture, and hence the UIV I chose as L1. So essentially I did L1, so one up from the L2 pathological fracture, skipping the L4. The other thing that I was thinking about intraoperatively is, should I have placed bilateral S1 screws as well? I mean, since I'm there and it's already obviously dissected out. But eventually I decided not to, because the pelvic screw purchase was very, very strong. These were 9.5 by 90, no, sorry, 9.5 by 100 screws. So this is the X-ray at 5.5 months post-op. I saw him maybe 3 weeks ago. He had no recurrence of pain, wound has well healed, no implant prominence, and no screw loosening. And he is now walking again. I just wanted to share just 2 more slides if time allows. I noted that Professor Tanaka was saying that 98% of Japanese surgeons now do S2AI screw, but in my institution we actually do the subcrestal iliac screw. This was published by Professor Gabriel in my institution back in 2017. And the reason why we do subcrestal screw, I mean, the reason why we do the subcrestal screw is, number one, it affords us to not have any need for any offset connectors because of the slightly more medial entry point as compared to the traditional iliac screws. We also do not run into implant prominence or wound complications or wound dehiscence from this subcrestal screw, because we ensure that the entire tulip of the iliac screw is buried underneath the crest of the ilium. And finally, not in this case, but in other cases, Prof. Gabriel has published that you can actually do this in MIS as well. Of course, S2AI, you can do it with MIS using O-arm, of course, but because the subcrestal iliac screw, the incision is just medial to your crest, that is easily done with a fluoroscopy using the teardrop view as well. So these are just the entry points for the subcrestal screw which are used in this case. Thank you very much.
I'd
Okay.
like to say something. So Shakespeare says, all is good if the end is good. Of course, the end is good, but you choose maximum surgery you have a navigation system. Why you don't choose MIS? You open, right?
Yes,
Previous
Professor, I did.
previous paper, it was MIS technique, but this surgery is open technique. And then you did a maximum surgery. You said this is a little bit bad condition and the life expectancy is not so long, but you chose maximum surgery. Why?
The honest reason why I did not do MIS was because of my relative inexperience, Professor. So I hope that with future training, I would convert to my tumor cases to MIS in future.
Thank you, Jun Hao. Like Dr. Tanaka said, in a few weeks' time, this tumor is going to recur. So what happened to this patient?
Sorry, Professor, you mean the tumor at the L4?
Yeah.
At
Yeah,
the L4
L4.
level, I took down the entire pedicle, and then from the pedicle, I went into the vertebral body to debulk the L4 vertebral body. So actually, at that level, the chorda is well free from any tumor cells. So at this point in time, when I first saw him last 3 weeks ago, or 2 or 3 weeks ago, he had no recurrence. I did not get an MRI scan again because he had no symptoms at this point in time, but no signs of recurrence so far.
So it's very recent. Would like to know what happens to it in the next few weeks' time, because most of them would recur and the pain also would recur.
Absolutely. I think the whole idea about the separation is that I'm trying to hopefully buy time by resecting the tumor, or rather debulking as much as I can. But absolutely, I think future or rather long-term follow-up would be needed to see whether the tumor grows again.
Well, one comment which I would like to make is that because the neural structures are very well decompressed, and even though the patient has had 2 prior radiotherapy, but I think there is still possibly option for stereotactic radiosurgery, because
Absolutely.
that would be very effective in a local control of the tumor, particularly when there is already a separation surgery carried out. So that could actually reduce the risk of local recurrence.
So this patient, he was already on follow-up with he was already known on follow-up with the radio oncologist. So at about 3 weeks and 3 to 3.5 weeks post-operatively, when my wound was healed, I gave the go ahead for the radio guys to start SBRT, because they know the conventional RT was not very helpful last 2 rounds. So they started SBRT at about 3.5 or 4 weeks post-op to control the tumor.
Any other comments, Ronald, Umesh, Niraj?
Yeah, I think that's the problem with over time. I have 25 or more years of experience. The problem with using scoring system is still very unpredictable. I think it's very difficult to just say that in this particular case this worked, and in your case that might also work. So yeah, it's a very, very difficult decision. But I also agree with Dr. Professor Tanaka. If I were to do this case, it's actually easy to do an MIS here, and then maybe if I need to, I just have to decompress the area. It's just a nerve root decompression. It's a very simple procedure. So if I need to do surgery.
I think I would agree with Professor Ronald that yes, I guess these are difficult cases and difficult to decide what is the best option. So whatever works for the patient. But as Dr. Ronald said, I will be for decompression at first stage. Maybe, God knows what's in the future.
One thing which we are always very concerned is the risk of surgical site infection after tumor surgery, because the occurrence of a surgical site infection would actually impact further oncologic treatment, such as radiotherapy, such as chemotherapy. So once they have surgical site infection, all these treatments becomes less feasible. So that's what we always counsel the patient, that despite we offer the option of surgery, if surgical site infection, let's say it happens in this case, then they cannot perform radiotherapy and even chemotherapy in the face of an active infection. So that is always one consideration which we always worry about when we offer the surgical option to the patient.
Can I give a comment on that, Chris?
Yeah.
I think in all my cases, I always look at the albumin status of the patient. So the albumin level is a predictor of morbidity and even mortality in these cases. So there's an option of building up albumin, and then although it maybe immediately post-op, you also need to build that up because that is somehow a predictor for morbidity. I think that's a good point to remember. Thank you.
Any further comments? If there are no further comments, actually we have one question from the chat box, which was earlier directed to Dr. Tanaka. So the question is about, there are two parts to the question. First is after occipital cervical fusion or stabilization, what is the allowable movement which the patient can perform? That's the question from the audience. And the second part of the question is, what is the risk of neurological injury with a reduction of any occipital cervical pathology? So this question is actually for the first speaker.
Okay. So if I choose OC fusion, so the cervical movement will be restricted. So how much percentage?
Yes, how much restriction would the patient have?
Because as I said, head flexion is one third is OC1, right? And then rotation C1 to about half. If you choose OC2 fusion, but flexion, the patient never complain anything. But rotation is a little bit difficult. Maybe will become half. We have a paper. We already report a paper about half. The patient always complain about driving and then see the back. It's very difficult for driving. But normal ADL, it's okay. Number one. Number two is again number two question.
The second question is the risk of neurological injury. Yeah, but during reduction.
Yeah. So we usually use neuromonitoring, and then first you should decompress first, and then gradually rotate and sometimes distract. But just rotate is not so dangerous. But neuromonitoring is the most important thing, and decompression.
Thank you very much, Tanaka. Yeah.
Can I answer that, Chris? Yeah.
Yeah, sure, Ronald. Yeah.
So that is a very good concept of Professor Tanaka because I always do that. To be honest, I have more occipitocervical cases than the thoracic spine. So in our cases, even in a severe kyphotic deformity, you can still actually intraoperatively manipulate the neck, the head. So the head holder, you can actually play with it as long as you have some neuromonitoring. The other thing is that if you do it slowly, it somehow is not traumatic to the spinal cord. So even in basilar invagination or even some fracture dislocation in the upper cervical spine, you can somehow manipulate the neck safely. That's my experience. Thank you.
Thank you very much, Ronald. There's one more question in the chat box. This is directed to all the faculty, but in particular to Ronald, I think. When do you decide surgery in thoracolumbar trauma in a neurologically intact patient?
Oh, that's a very good question. I use the TLIX scoring, so I try to be as objective as possible. So look at the numbers there before you decide whether you need to do surgery or not. Okay, thank you.
What about the other faculty? Do you use the TLIX score?
Actually, I don't trust TLIX score. So TLIX score is just an agreement. This is not based on some policy or something. So sometimes they discuss, this is TLIX score 5, that's why it's a candidate for surgery. This is just 3, it's not the candidate for surgery. I don't agree. This is not a perfect, you shouldn't say such a thing to Bacaro. I don't trust completely.
Yeah.
If thoracolumbar fracture is more than 30-degree kyphosis, it's a malunion. So even though the patient don't get the surgery, always patient complain back pain later. So in that situation, I do surgery, even though the TLIX score is low.
Yeah, I think that is the correct answer. Not many people would do the scoring. So the important considerations are the neurological instability and the mechanical instability. Now the patient is neurologically intact. So let's focus on the mechanical instability. If the patient has a type B injury, that is the posterior column is gone, it's not there, it has to be stabilized. If the anterior column is lost by 30 degrees, that Professor Tanaka said, that means the posterior column is lost. That is an indirect indication that the posterior column is gone. So it has to be restored. So whenever the mechanics are unstable, we have to restore it.
Completely agree, Professor
So
Arif.
I guess I would agree with Professor Khan. You know, I think for me the decision making is mainly by the PLC. If there is posterior ligament injury is present, you know, unequivocally it requires surgery. It's the confusion is about AO type A. You know, A1, A2 is as such conservative. The main confusion comes in A3, A4. So it's all about, you know, whether this fracture would collapse eventually or not. So bone quality, younger age, as Professor Tanaka and Professor Khan said, you know, more than 50-degree collapse, more than 30-degree angulation, where, you know, these are indirect predictors of eventual collapse and instability. So I guess your fracture configuration and PLC injury, there's two things decides in addition to TLIC score. So we also use TLIC score as well as this morphological parameters to decide in a neurologically intact patient whether surgery is required or not.
I agree, Dr. Niraj. Thank you.
Thank you, sir.
Any other further comments? If there are no further comments, then it's time to close this webinar session. I've enjoyed the interaction, the lectures, and the discussion between all the faculty and all the presenters. I think I like it when it's very open and everybody speaks their mind. So I will leave the closing remarks to the chairperson of this webinar, Professor Arif Khan, to give the closing words.
Thank you, Chris, and thank you, everyone. It was a great webinar. I thoroughly enjoyed it, and I'm sure everybody enjoyed it. All the presenters, Professor Tanaka, Professor Ronald, Umesh, Naguru, all they presented great. Dr. Jun Hao case was excellent. So I think we all learned from it, and all the faculty as well as the participants have learned from it. I'm thankful to the Secretariat, the Anna, Candice, April for being with us here and providing us all the services. I'm thankful also to the OrthoTV for giving us this platform to use the webinar. And thanks again to all the participants for being with us. And let's be part of the future webinars as well. So thank you very much and bye-bye.
Thank you, Professor Khan. So
Bye-bye. Thank you very much, everyone.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Yeah.
Bye-bye.
See you in Cebu.
See you.
Bye-bye.
Professor Tanaka, see you in Cebu.
Bye.
Bye.